right, welcome. It's great to have everybody here today. We have a really big group, several hundred people joining us this afternoon, so it's going to take just a moment for everybody to log on. We have a quick poll. We'd love people to answer. One, I may go that slide, and if we could put the poll up here. I don't see the poll, but hopefully you guys see the poll, if we can activate the poll. So we'd like you to tell us if you're aware of how SDOH data is being collected and used in your state. So you'll see a question up there, and just click yes or no for us, and we'll share the results of that later. But we are really curious, given what we're going to talk about today, how many of you know about SDOH data and how it's being used in your state? So let us know. Hello, Dubai again. Great to see you. Mazine from Dubai, welcome. Mike Rogers, Silicon Valley, welcome, guys. Pennsylvania, welcome. Just if you could take a moment and fill out the survey for us here, this one question. We want to know how many of you are actually aware of SDOH data being used in your state. Let us know and respond to that survey for us. We have a really good group with us here today, so welcome to everybody. Toronto, so great to see Toronto. Alabama, Roll Tide. Welcome. You guys are great. Any basketball fans here? A lot of games going on this week. Sunshine State, welcome. Good times. All right. All right, Stuart, you keep us up to date on the NBA trade deadline today. Vermont, great to hear from you. Gonzaga, all right, great. Well, I've got a couple of housekeeping items I'm going to go through. So hopefully everybody has seen the poll up there and can respond to the poll. Are you aware of the use of SDOH data in your state, yes or no? And if you could respond to that, that would be great. Welcome. Couple of housekeeping items before we get started. We are trying some new things out today on Zoom. We are upping our Zoom game today. So there is a poll there we'd love to have you respond to, if you could do that for us. And second of all, I think most of you know you're muted, but we do want to take as many Q&As, questions in the Q&A box as possible today. And we know we've got a lot of participation from folks out there on SDOH. We're doing a new thing today where if you click on the Q&A box, if you see a question that you have the same question, go ahead and give that question a thumbs up. And that is called upvoting, and that will help us know which questions to answer first and which ones you guys are really interested in hearing about. So sometimes we get so many questions during the course of a webinar that we can't get to them all. So this will give us a better sense of what you guys are interested in hearing about, and will help us prioritize the questions that we do get. So we are trying that out today, so we'll see how that goes. If you have any questions in the chat box, technical issues, Sarah and Monet are happy to help you. So go ahead and put that in the chat box. You can also put your basketball picks and your hometown as well. Happy to see that today. All right, next slide. All right, so I am Jen Kovich-Bordenick, the CEO of the Ehealth Initiative and Foundation, and you're wonderful, delighted to be with you today, moderator. Happy to be here in beautiful Washington, D.C. Spring is finally sprung here, which is great. We have a fantastic panel today looking at SDOH really around the country, starting with Diana Ziskoff, who's the Director of Market Planning Strategy of Government Healthcare and Public Health LexisNexis, one of our frequent flyers and expert presenters talking about SDOH. Diana's been with us before and is just super, got a lot of experience talking about how they're working around the country right now. We've got Gary Singh, who's the Director of Delivery System Investment and Social Services Integration at Mass Health, a very, very forward-thinking group doing a lot of interesting work right now in the wonderful New England state. We have Dr. Chris Chen, who's the Medical Medicaid Director of the Washington State Healthcare Authority. It's got really interesting take on what they're doing there, have started some new initiatives. I think you're going to love hearing from Chris. And then Stephanie Bennett, who's the State Health IT Coordinator at the Office of Ehealth Innovation for the state of Colorado. So we're kind of hitting a lot of different corners of the country today. So glad to have everybody here today. And then we will get to Q&A as quickly as possible and get to your questions. And then we will wrap up the day. So again, go ahead in that Q&A box. Feel free to add your questions in there. And then if you see a question you like, there's a little thumbs up button underneath the questions in the Q&A box, and click that if that's something you want to see the answer to. All right, next slide. These are just a sampling of some of the organizations Ehealth Initiative is working with. If you do not see the name of your company there, it needs to be there. And you need to send me a note through the chat box and tell me that you're interested in getting involved with us. We would love to have your organization collaborate. We're a nonprofit, 20 years, bringing together executives from across the spectrum of healthcare. Next slide. We do education, advocacy, and thought leadership, just like we're doing here today with a series of panelists and educational programs covering 4 distinct areas. We go to the next slide. We work in privacy, virtual care, social determinants of health, and of course, COVID-19. So all of our education, thought leadership, and advocacy is around these 4 critical issue areas. Next slide. And we've got a wealth of materials and resources available for you online at ehidc.org. This is just a sampling of some of the programs and webinars we have done in the last several months. And I encourage you, as a nonprofit, we want to disseminate as much information as possible. Please go to our resource center and feel free to download and share any of this information. Next slide. We've also got a number of reports we have released in the last several months. This is just a sampling of them, but a lot of work done on SDOH for those of you who are interested. We have a couple of different reports looking at American Indian and Alaskan Native communities, how tribes are working with COVID-19 and dealing with the challenges right now and incorporating SDOH data. We've got a great set of principles that we developed actually with the support of LexisNexis last year, looking on what's the appropriate way to use SDOH data in health. And a great paper on the way to do that appropriately with some great case studies. So really good work on SDOH if you're looking for reports and publications. Next slide. And a couple of important dates coming up. We're going to be talking about vaccinations on April 6th. We'll be talking about patient matching on April 1st. And on April 14th, we'll be talking about COVID-19 lessons learned. And how to apply this to value-based care. We also have an SDOH analytics work group. So if that's something that you're interested in, we are pulling together recommendations for different items there. We have a policy briefing and a policy work group coming up on April 20th. So please reach out to us if you're interested in getting involved. And I want to thank LexisNexis, who has been really an avid supporter of a lot of our work. As I mentioned, Ehealth Initiative is a small nonprofit. We wouldn't be able to do the education and research and advocacy without the generous support of organizations like LexisNexis that allow us to do this important mission-driven work. And so thank you. And thank you, Diana, for bringing your expertise with us here today. Appreciate that. And here are our wonderful panelists, as I mentioned, and while we're taking a peek at them, you're going to see their faces for real in just a moment here. But let's pull up the results of the poll if we can and see how that turned out before we dive in here. Let's see, polling. Okay, can we show the results? This is what happens when you try new Zoom features. Okay. All right, so here we go. So 46% of you are actually aware of the use of SDOH data in your state, and a little over half are not. So I'm not sure what that means, but that'll be interesting to get the take of everybody here. Is it that they're not happening in different states, or perhaps people are just not aware? And this is clearly a group that's interested in SDOH. So this will be interesting to hear from the different states specifically, how you let people know about your efforts. So great. And with that, I'm going to turn it over to Diana, who's going to kick us off here. Diana, it's all yours.
Hey, everyone. Thank you so much, Jen. And thank you and Ehi for helping us get this event together and for pulling such a great attendance number. So impressive. And thank you to everyone joining. As Jen said, my name is Diana Ziskoff. I lead strategy for the government healthcare business at LexisNexis Risk Solutions. I'm going to talk a little bit about what that means. But I'm also a public health practitioner. I've been in a state health department like many of you, and I know that this has been a really big year for equity for all of us who care a lot about equity and disparities. So I want to take a minute to kind of recognize that. I'm also an immigrant, so I understand on a personal and family basis how important social determinants of care are and how amazing a lot of the work is that our providers and our care coordinators are doing on the ground. When we were putting together this webinar and kind of brainstorming with Jen and her team, we really wanted to take a step back and think about how do we best recognize the great work that's happening on the ground. And one of the ways that I want to do that is by really framing this conversation around the policies, the infrastructure, the data, all of those kind of back end things that we need to help make our providers and our communities more successful in making social determinants of health sustainable over time. So I'm really, really grateful for all of our panelists for joining me. Thank you so much. And so grateful to have 300 plus of you all listening in today. So let me tell you a little bit about who LexisNexis is, if you're not familiar with us, and kind of how we think about the role of data in social determinants of health. So we are at its core a data aggregating company. Most of what we do is take public records that are available in the private and public domains and pull them together. We have over 78 billion public records coming from over 10,000 data sources. And that includes private sources. So things like when you're looking at cell phones, we get feeds from the major cell phone carriers when someone updates their phone number. It also includes credit history and of course, public records. So marriage licenses, criminal records, vehicle registrations. And as that starts to stack up, you can imagine that that really helps us understand the whole picture of an individual. And what's unique about LexisNexis is our ability to link those 10,000 sources of data for Diana Ziskoff down to one record with one profile that speaks to my best address, my historic addresses, my voting pattern, my education, my income, where my relatives live, my access to transportation, my access to housing, things like that. So we do that, kind of take that core of data and apply it to many different challenges. We're going to be talking today mostly about our data management and data enrichment portfolios and how that intersects with social determinants of health and how we have a clinically validated socioeconomic attributes of health specifically designed to help states and payers and providers look at their social determinants of health for their population. So if we go on to the next slide, I often kind of use this phrase, and Jen and her team have heard me say, whole person care, the vision of this really great infrastructure really starts with whole person data. So getting one complete data story between what's happening in the healthcare system and what's happening outside the healthcare system. It starts with that really solid data foundation, and whole person data often sounds with infrastructure. And this is where, I'll be honest, I'm a health communications person and a public health person. If you get too technical, my eyes start to glaze over, but it's really about the infrastructure in helping weave together what is a very fragmented social and clinical safety net. So I think of this in three kind of core steps, and a couple of my fellow panelists are going to be digging into these. So I'm excited to hear about their real life examples. It really starts with interoperable data sharing. How can we take all of the databases that we have from integrated eligibility, social services programs, healthcare, public health, and use the connectivity between them to help combine data? Once all that data is combined, how do we then get it down to one specific person? A couple of the panelists, I believe Stephanie is going to be talking a little bit about how they've used a master patient index, which is a fancy way of saying, one identifier that helps link one person across all of these databases. So again, getting to that vision of whole person care really starts with that whole person data. And then I'll talk a little bit about how you can enrich that data to provide the context. Often as a healthcare entity, whether you're a Medicaid agency or public health agency, you might have the data on the healthcare system, but we're kind of limited often with what happens outside of the healthcare environment. And we all know that that's really where chronic disease management and social determinants of health come in most importantly. So that's where third-party data, like what LexisNexis provides, can be super, super helpful in enriching your data set and painting that picture outside of the healthcare environment. So if we go on to the next slide, I'm going to touch on that. Oh, I forgot that animation was there. I'm going to touch on that briefly. So like I said, social determinants of health happen outside of the healthcare system. That often means that we need data outside of the healthcare system to kind of fill in those gaps. As a program manager, when I was at a State Department of Public Health, I spent most of my time managing screening data, right? You would have some sort of self-report questionnaire or intake form, maybe a survey that you were doing out in the community, which was fantastic, but it never really felt like I had the ability to have all of that data on the full population. And unfortunately, often the people who are most at need for social services or for support weren't the ones filling out the survey, right? So that's where, I think program data is incredibly valuable, and I do not want to gloss over that as well, but I want to think about how do we enrich that and add to it with third-party data. And a great place to start is with updated demographics. So LexisNexis supports pretty much all of our state healthcare clients with some form of updated contact information, best phone number, and we also have the power to then look at social networks. So who's nearby, relatives, relationships can also help understand, what the picture of health looks like for that person. And then the richest layer is really when you start getting into the socioeconomic attributes of health. So we have built 400 plus attributes that have been clinically validated to impact health costs and outcomes. And they are also categorized into risk models around readmission, high cost of care, utilization, to help also, predict how social determinants of health could impact someone's interaction with the healthcare system, and again, provide that enrichment to flag, hey, based on the data that we have in the public records, we have a predictor that says this person might be at risk of homelessness. Let's make sure that we, flag that for our state healthcare colleagues to then go ahead and follow up with them on the ground. So just to summarize, I think non-traditional data is public records, often called kind of non-traditional because it's non-clinical. Great way to enrich that socio-demographic and social determinant data and complement any kind of self-report that you are doing on the ground at your agencies. So with that, I think if we go to the next slide, I obviously want to get over to the questions as quick as possible. Here's my contact information, and I'm going to put it in the chat as well. So if anyone's interested in learning more, please do reach out. And Jen, I'll turn it back to you.
Thank you, Diana. Fabulous. Now we're going to go to Dr. Gary Singh from Mass Health. Welcome, Gary.
Thanks. Hi, everyone. My name is Gary Singh. I'm the Director of Delivery System Investment and Social Services Integration at Mass Health. And for those of you who don't know, in Massachusetts, Mass Health refers to the Medicaid and the Children's Health Insurance Program. And so we currently cover around 2 million members. So I'll just give a little bit of background before I dig into this topic. So Mass Health implemented managed care in the early 90s. And since then, we've made incremental changes up until 2017, which is when we decided to make a major shift in our managed care strategy by introducing accountable care organizations into the mix, or ACOs. So I won't go into all of the details about ACOs, but at a super high level, instead of paying providers on a fee-for-service basis, we set a budget for our ACOs. And if they spend more than the budget, they have to eat some of the excess. If they spend less than the budget, then they get an opportunity to share in some of those savings. So really what this shift in payment approach does is it really incentivizes ACOs to think about, okay, how can I start to take some innovative steps to improve quality or to reduce cost of care? And so this is where a focus on social determinants of health, or we often like to say health-related social needs at Mass Health, that there really is a lot of alignment between the total cost of care budget approach and this further upstream approach. And this focus is something we've been focused on for a while now, and it really reflects our commitment to whole person-centered care, as Diana was saying earlier. Is so important. And this focus also builds on more and more evidence that says that addressing these needs leads to improved health outcomes, reduced total cost of care, and potentially helps to reduce health inequities. You know, maybe not surprising, in Massachusetts, just like the rest of the country, people of color are disproportionately impacted by health-related social needs. So as an example, Black and Latinx individuals make up 9 and 12% of our state population, but they account for 35 and 40% of the individuals who are experiencing homelessness. So really significant differences there. 25% of Latinx and Black individuals who are 18 years or older in Massachusetts have low or very low food security, as opposed to 13% for their white counterparts. Right, so clearly there's a lot of opportunity here for improvement. So the question is, what are we, Mass Health, doing in working with our ACOs in addressing the health-related social needs of their members? So if we want to go on to the next slide, we've got a little simple framework here that has helped at least me to think about and to structure the various initiatives that we're doing. So the first bucket is creating the right incentives for our ACOs to pay attention to health-related social needs. So I've mentioned the total cost of care accountability piece, so I won't really speak too much about that anymore. But a key element of that is setting the budget or the benchmark. And so one question is, well, how do you do that? In Massachusetts, we've really tried to pioneer an approach of including social determinants of health variables in our risk adjustment. And so two variables to just highlight here. One is unstable housing. What we've done is this particular variable focuses on whether or not the member has a Z59 homelessness code in their claims or encounter data, and or if they have 3 or more address changes in the last year. And then the neighborhood stress score, this is actually derived from US Census data and looks at the zip code of where the member resides and whether that neighborhood has more or less stress compared to other neighborhoods in the state. So once we've created the right set of incentives to pay attention to HRSNs, we want to move to, well, in order to address the needs, you have to identify the needs first. And we contractually require our ACOs to annually screen all of their members for HRSNs. And we've actually tied financial accountability to it. We've created a quality measure for this. I've added it to the ACO measure slate. And depending on performance, ACOs can receive more or less financial rewards for it. Once the needs are identified, it's important to connect members to services that address the identified needs. So we also have a contract requirement to connect members to services for those needs. In addition to that, we've established a companion care coordination program for certain members with behavioral health and long-term care needs. And as part of that, these entities, we call them community partners. A large part of their work is connecting members to services to address these needs. Oftentimes, members want to pay attention to these needs first, even before they start thinking about their physical, their behavioral health, or their long-term care needs. Now, it's all nice and good to be able to connect members to services, but if there isn't funding for those services at the receiving end, then it's almost like you're creating a bridge to nowhere. And so Mass Health has really tried to think about what can we do to help pay for some of those services. So for a while now, we have included certain housing supports in our managed care benefit for our members. And in particular, this benefit is for folks with BH needs and who are chronically homeless, according to the US HUD definition. And it includes pre-tenancy support, so helping people to find housing and to stay in the housing once they've identified it. In addition to that, we've layered on a pilot program, which we call the Flexible Services Program. And it's about $149 million. It's part of our current DSRIP program, which is in our 1115 waiver. And it basically provides additional funding to ACOs to pay for certain housing supports and nutrition supports. And we really view this as an exciting opportunity to test to see whether providing funding for these services actually will make a difference in improving health and reducing total cost of care. And finally, this fifth category here, providing supports for success. We know that there's a lot of work to be done in this area, and so we as a state have tried to think through what else can we do to help support the ACOs in this effort. So we've given infrastructure funding to the community-based organizations that are delivering that flexible services on the ground. And so we've partnered with our Department of Public Health in administering this grant program. We've also made robust technical assistance available to the ACOs, specifically about the Flexible Services Program and social determinants of health in general. And finally, this last one is an example that came about more recently because of COVID, as is probably similar to many of your states. In Massachusetts, food insecurity really spiked because of the economic pullback. And so we worked to coordinate with our sister state agency to figure out, our sister state agency that administers the SNAP program, which members are enrolled in SNAP. We compared that to our Mass Health roster and identified which members were eligible but weren't yet signed up. And we gave personalized lists of those members to our health plans, including our ACOs, so that they could do a little bit more targeted outreach to see if they could get those folks enrolled in SNAP. So all of this, much of this work centers and relies on SDH data. And so I've just highlighted in blue a couple of items here and would be happy to speak more to that data connection later on during the discussion. But I think this helps to provide a bit of an overview for some of the work that we are doing. So I'll turn it over to Jen.
Thanks, Gary. Appreciate it. Okay, I think we're going on to Chris Chen, Dr. Chris Chen. Great.
Thanks, Jen. Hi, everyone. My name is Chris Chen. I'm an internist, I'm a hospitalist, as well as a medical director for Medicaid at the Washington State Healthcare Authority. So happy to speak with you guys today. Next slide, please. Just a little bit about the Healthcare Authority. In Washington State, we are the state's largest healthcare purchaser. We purchase healthcare for more than 2.5 million Washington residents through a few different programs on both the Medicaid and the commercial side. So under Apple Health, our name for our Medicaid program, we have about 2 million individuals. And on the commercial side, we provide healthcare coverage for public employees as well as school employees. Next slide. So I think I wanted to put a little bit of the context around our interest in social determinants of health in terms of kind of social determinants in general. You know, I think as a physician, I think the healthcare community is kind of waking up to this concept of social determinants or health-related social needs over the last couple of decades or so, which is really not something that's new to our social services or public health partners. And I think it's something that has been recognized by state agencies for quite some time about the needs to have good policies and supports for housing, for education, for employment, and all of these determinants that ultimately result in health outcomes. And so I think putting that in the context helps ground us a little bit into what healthcare's role is. And I just want to share how important it is to have this work led and collaborate with our social services partners. And just on the right-hand side here, I have one of the slides from one of our sister agencies, Department of Social Human Health Services in Washington State, which has a data shop called RDA that manages source data from a number of different agencies, including our DSHS, our Healthcare Authority, which is our Medicaid agency, our Department of Children, Youth, and Families, as well as other agencies. And so that's data that's been used to support various programs for quite some time, including TANF and SNAP and WIC and all these other programs. And so kind of along those same lines, I wanted to highlight a really exciting body of work that is being led by our DSHS called the Dismantle Poverty Group in Washington. And this is really a multi-stakeholder collaborative that is meant to take a really hard look at how we support those who are most affected by poverty and injustice. And it's co-led by multiple agencies in partnership with tribal and urban Indians, state, racial, and ethnic commissions, employers, and community-based organizations, as well as advocates. And so an exciting body of work. There's a 10-year plan that's available on the Dismantle Poverty website that I think would be interesting for many of you to review. And also kind of sharing where we are, Washington State, and our Opportunity Index, which is a metric of housing, health integration, employment, and education. Just, you know, I think we didn't get to this position of being a state that is relatively positive for people who are seeking opportunity and looking to improve their lives. We didn't get there because healthcare got us there. We got, you know, I think, and so just trying to keep in mind, you know, how are we thinking about our role as healthcare providers in the scope of social determinants, and we're not trying to kind of replace programs, but we're trying to augment them. And thinking about the patients that kind of go in and out of our ED doors, a homeless individual who may be hospitalized multiple times, but never end up getting the resources that they actually need. So how do we bridge that gap between clinical and social care? And you know, as Gary was mentioning, incentivize our healthcare providers to kind of connect people to the right services and move that upstream. So just want to ground a little bit of my discussion in that. If you go on to the next slide, I would say Washington Medicaid has an evolving approach to social determinants data. Part of this is also, it's also part of our overall data strategy, which is also under development. But I wanted to highlight a few different areas of things that we're thinking about as it pertains to social determinant data. Really hone in on just this first one under generating and managing social determinants data is how do we establish and maintain trust? And I think this may have been raised in one of the Q&A boxes too around certain ethical issues. And you know, there's a reason why some of this data is unavailable or difficult to aggregate. And that's because it's sensitive information with communities that may not always trust, quote, the system in having this kind of data. And I think even when we speak about basic race ethnicity categories, there are people who are cautious and don't know, you know, whether or not if they disclose what their race or ethnicity is, will that information be used for good? And I think, especially when we kind of, I think I've seen examples in my personal practice of, for example, someone who is concerned about revealing homelessness information about their housing status because they're afraid that their kids may get taken away from them by CPS. Or examples of, you know, an individual disclosing their interpersonal violence status and whether or not that's something that they want to share with their providers and have available on their records, especially as we think about kind of the move towards interoperability and how this data is exchanged and displayed, you know, with open notes and, you know, patients having access to more of their clinical records. You know, it's very easy to imagine that like a physician who's just typing a clinic progress note and pulls in the social history and through a template, you know, may have someone's interpersonal violence history displayed there. And I think we have to be really thoughtful and careful about how we use this data and how people, because it can be so sensitive. And part of it is also about normalizing experiences. I think we've had, as a society, a history of kind of stigmatized medical or behavioral health conditions that ultimately become kind of a little bit more normalized, and how do we get people more comfortable in talking about these kinds of things. But it's just of utmost importance that we kind of work with communities and establish and build that trust. I think one way that we've done this recently through our Health Benefits Exchange, our Washington Health Plan Finder, which is where people enroll in Medicaid, is by explicitly stating more completely at the point of collection of the race ethnicity data that we also added a statement that says we use this information to make sure that everyone has the same access to healthcare. And if you choose to answer them because they're not required, your information will be kept confidential and it won't be used to determine what health insurance you qualify for. So I think it's really important to kind of be upfront and establishing that trust. Also in the lines of generating and managing social determinants data, I think we're working to align with national standards where possible, while allowing flexibility for programmatic needs. We participate in the Gravity project, One way where this is manifested recently is all of our managed care organizations perform screenings for social determinants needs and medical and behavioral health needs when someone enrolls. And so we asked our plans to use 3 standard questions that if they ask them, then they use these 3 questions that kind of map to Gravity project standards. And I think that's really important to kind of maintain standardization for the purposes of reducing reporting burden, which leads to the next category of thinking about how we exchange and disseminate social determinants data. Kind of on my previous slide, I shared that there's a lot of this information already in our systems because of various social service programs that we offer our clients as a state. And so how do we think about minimizing reporting burden for clients, you know, given that an individual's race ethnicity may not change many times over the course of their life, although certainly definitions and categories and kind of the specificity of them do change. How do we think about not asking people repeated questions over and over again, but also, you know, if things do need to be updated, how do we make sure that's done effectively? And I think that's our master person index, as well as our integrated eligibility work in Washington State is really important to facilitating that. We also have accountable communities of health in Washington State as part of our Medicaid transformation waiver, and many of them are working to support community information exchange. And so I think that's a really important bridge between the clinical and the social services sectors in terms of making sure people get the resources that they need. And then finally, thinking about intervening on social determinants of health data, because there's no point in collecting it if you're not going to act upon it. And I think that's very much part of establishing and maintaining trust, is that when someone discloses a need, that need is addressed. And so we are thinking about resource and referral, as well as coverage and benefit design. How do we think about paying to support different health-related social needs? Another one of our programs out of the Medicaid transformation waiver in Washington State was foundational community supports. And this is a supported housing and supported employment initiative that created a benefit for these programs and helping clients navigate resources with very positive outcomes, and both clinical and social outcomes in terms of more likely to receive housing supports, more likely to be employed, higher earnings, as well as reduced ED visits, reduced hospitalizations. And so I think that's a really fantastic example of a program where we're able to intervene on social determinants of health data effectively. And other ways that we are exploring include incentives and payment and risk adjustment. We are more intentionally stratifying our quality measures by race ethnicity to identify those disparities and think about how we hold our various partners accountable for working to improve those disparities. There's also, we also have an incentive program that rewards hospitals for screening for social determinants of health. And so all of this, we're working very closely with our various partners around the ecosystem and hoping to let our community and social services partner lead as well.
Great. Thank you so much, Chris. Appreciate it. All right, we're going to move on to Stephanie.
Hello, everyone. I'm Stephanie Bennett. I'm the State Health IT Coordinator for Colorado's Office of Ehealth Innovation. The Office of Ehealth Innovation, or OHI, is the state designated entity for high-tech funding and all federal health IT funding, and we're located in Lieutenant Governor Diane Primavera's office. Next slide, please. Just a little bit of background on our office and efforts. OHI's primary goal is to advance the Polis Primavera administration's bold health priorities through Colorado's health IT roadmap initiatives. The eHealth Commission advises OHI and the state on Colorado's health IT roadmap efforts, and we're actually currently refreshing this strategy and roadmap to focus on key themes that have emerged since the launch of the roadmap in 2018. Those themes are listed here, and today, here to talk about the Social Health Information Exchange, or the Care Coordination Initiative. The goal of this initiative is to coordinate care in our communities by leveraging existing tools and infrastructure. And to lead this initiative, we worked in collaboration with community partners as well as our fellow state agencies, including our state Medicaid agency, Healthcare Policy and Financing, the Department of Public Health and Environment, and the Department of Human Services. And this initiative is foundational to the state's efforts to reducing healthcare costs and increasing access to healthcare throughout the state. And we're focusing both on behavioral and physical healthcare. Next slide, please. So let's dig into the Social Health Information Exchange. To a little bit of background for our care coordination initiative, we mapped out all of the complex systems involved in this space to determine a starting point. And that work led us to this Social Health Information Exchange, also known as SHE. We're defining the SHE as an interoperable and flexible infrastructure that supports coordinated whole person care defined as physical, social, and behavioral health. So just like my fellow panelists have been talking about, really integrating those social determinants of health into our primary health care. And this is focused on these 4 key components on the left side of the slide. You can see it begins with the screening and assessing of a patient's social needs, finding the appropriate resources for that patient, referring and connecting the patient to the appropriate resources, and then confirming and recording that that referral was made. So in this way, referrals to social programs can be made directly to a community organization from a primary care provider. So for example, if a patient's experiencing food insecurity, they can express that need to their primary care provider, who then can refer them to a food bank in real time, saving that patient time and research of their own to get to that same food bank. So we see the SHE ecosystem as interacting in this flexible and interoperable way. And to develop and define this model, we worked collaboratively with community organizations, health information exchanges, 211, and our federally qualified health center tech partners. We've completed the planning stage, and we're now in the regional project implementation stage. And these regional projects will inform a statewide ecosystem and model. For this model to be successful, it also needs to be sustainable, which means both the infrastructure and the information exchange must support value-based payment. All of our current implementation projects must align with Gravity project standards, which Chris just mentioned, as well as our information governance efforts to ensure interoperability of non-proprietary data and systems across the state. And this is to ensure that basically the same thing that the other folks have said about data and its use, and really thinking through its responsible use and how patients are willing to share it. So both state and local governments have a key role in both data and information governance. In this context, data governance is focused more on the individual data elements in use, while information governance is focused more broadly on establishing processes, best practices, and the structures for the information sharing, and really laying that foundation, which is more what we're focused on in this SHE work at this point. Thank you so much for having me today. Please visit our website. I'll put my contact information in the chat, and we have lots of resources, white papers, and our roadmap on our website.
Great. Thank you so much, Stephanie. Well, let's get all of our folks up here, and we've got so many good questions here. I'm actually going to just jump into the audience questions to make sure we get a chance to respond to these. One really popular question, so we're using our upvoting today. Can you guys provide some successful examples of HIEs that have integrated SDOH data with their clinical data and talk about the resulting impact? So do any of you have solid examples of that with the HIEs? Stephanie, I know you do. Chris? Gary? Who wants to jump in? Diana? You guys are all on mute, so can you hear me?
Yes.
Okay. All right.
I can start real quick. Yes, as you said, we do. So our regional implementation models, actually a couple of them are based in the health information exchanges. So one of our health information exchanges is based on the western slope of Colorado, and they've created their own version of this, where they're integrating that social determinant of health data and working on this closed loop referral.
Great. Anybody else got a good example? I know somebody put San Diego in the chat box, Washington State, certainly.
We have a number of different examples from around the state, kind of more regional initiatives, where some of our accountable communities of health have really worked with their public sector, nonprofit, or community-based organization partners in partnership with healthcare organizations to improve kind of that care coordination for individuals. So some different examples from around the state.
Okay, great, fabulous. Let's see, who else do we have here? Wonderful. All right, from Nat, do you have some examples of SDOH assessment tools? Kentucky HIE is working to align ICD, Z codes, and LOINC codes. Wondering what types of assessment tools we should look at to align next. Anybody have thoughts on that?
I can take a first stab at this one. So in Massachusetts, we've taken a little bit of a different approach in terms of what assessment tools we allow our ACOs to use, but and so we haven't chosen a single tool that everyone needs to implement, sort of like what North Carolina has done. Instead, we've identified a couple of core domains that ACOs need to screen for, and those core domains are housing, nutrition, transportation, and utilities. But what we have seen is that many ACOs have used tools like the CMS Accountable Health Communities screening tool. There's another one, a popular one called Prepare. I think I've got it here, Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. It's from the National Association of Community Health Centers. So, the AHC screening tool and the Prepare ones are are common ones that we have seen. But I think there are a decent number of good tools out there. If you are able, as a state, to be able to identify a standardized screening tool, it will make your life a lot easier and will help to promote the interoperability between different referral platforms if and when you're able to get something like that off the ground.
I'll just add, I think kind of Washington State, I think we're a little bit adolescent in this area. We don't have a standard screener. As I think about things, they're it's not always a same set of 10 exact questions that you need to have asked in every situation, but kind of when those questions are asked, like in the specific domains that Gary was mentioning, how do you think about your level 1 screener questions, your level 2 questions to get a little bit more deeper into the need that is there, and then like your level 3, 4 questions to serve various programmatic needs. So I think thinking about what our standard question banks look like, how do people kind of still serve the need that they have for the community, and at the same time while kind of aligning to these standards. And so as much as we can, we do look at things like Gravity Project, the work that's coming out, the interoperability standards from ISA, things that kind of align with EHRs and those standards to kind of make sure that we're all kind of connected.
And that Gravity Project is a great project. We had someone on last week talking about that, so great resource as well. Diana, I knew we were going to get this question about ethical issues arising. We spent a lot of time working on the ethical use of SDOH data. Can you talk about kind of the considerations that need to be taken in terms of using this data?
Yeah, it's a great question, and I'm glad that I think Ben put it in the chat. I think it's a really important one. So I think just to clarify, when we're talking about, kind of aggregating public records and, this is very different from what you might encounter from like a marketing agency. We're talking about extremely regulated sources of data that have very specific permissible uses. And when we work with a state healthcare client, we go through a very detailed process to understand how they're using the data, who will be the custodian of the data, actually going through a pretty rigorous credentialing process as well. And part of that is really identifying the use case. So in some cases, we have clients who pull this data into their general care coordination or risk adjustment algorithms. And I think Gary and Chris touched on that a little bit in, making sure that this is a piece of your story, not the exact, piece that you call someone up and say, hey, I see that you're homeless. The flip side of that is we do also have that kind of end product that can guide care managers better. And so we do also, provide a list of questions and kind of approaches and best practices to using that kind of data in a way that makes sure that we can, approach a client without compromising any consent or any sensitivity. And I think, Chris touched on it really well. A lot of it comes down to thinking through exactly how the data is being used, making sure that the staff is properly trained, making sure that consent for any self-report measures is considered. And that's something else that we're really actively thinking about is when we're talking about all this interoperability, what is the granularity of consent for some of this social data, and making sure that that's built into your process when you are collaborating across programs.
And
so great question.
Yeah, I think we put in the chat as well. Sarah put a link to the paper. We actually developed last year in a multi-stakeholder process, working with dozens of organizations, guiding principles for using social determinant of health data ethically. And we also came out with use cases and examples of how this is being done currently right now around the country. And, and I would encourage you to take a look at that piece. I mean, a lot of it is about being upfront and honest about when you identify the data, having direct conversations with patients about the data and how they're being identified, about resources, making sure that they are actually linked to resources to address issues. This is a really critical issue, with all of this SDOH work going on right now, that we need to make sure people understand there is an ethical way to do this, and it can be done appropriately, and it is being done ethically across the country right now in a number of places. So, Sarah, we'll link that out, send that link out again to folks just so they have a copy of that information. Really important question there. Curious if any of the panelists have any specific federal policy wish list items for the Biden administration and beyond. This will be interesting. Yeah, let's hear it, Gary.
And is that a question from a federal official? Because yes.
Doesn't look like it, but I think we all have wishes. Gary,
yes.
Go first.
Well, one thing just immediately comes to mind. We all know the issue with EHR proliferation, where there are just so many EHRs, and I just see this happening right now with the electronic referral landscape. So if there is a way that ONC or CMS can I don't know, get ahead of the ball here, and maybe this is probably too much of a dream, but identify a single social health information exchange platform for the entire country, or at least identify what are some of the interoperable data standards, which I know is the approach that Colorado is taking as well. But this is definitely an area where the federal government has an opportunity to show some leadership here.
Okay, Chris, Stephanie, let's hear your wish list.
I'll go.
Yeah, go ahead, Stephanie.
Thanks, Chris. Our wish list is probably long as well, but one related to the topic at hand would be a bit more flexibility from CMS to onboard more rural providers, as well as community providers and behavioral health providers to the health information exchanges. We've made some great progress through high tech and other federal funds, but with that changing in September, probably, we really are looking for more flexibility there, more opportunities to onboard them in order to make all of our dreams on this call a reality.
Yeah, and I think just a couple of things. So certainly, yes, kind of agree with Gary's point, and also just jumping off that a little bit, the technology and health information technology available to providers has been uneven, with larger health systems, larger medical groups having more access to robust electronic health record systems, whereas people who kind of take care of the most vulnerable and disadvantaged, and you're thinking are individuals who reside in long-term care settings, adult family homes, rural providers, behavioral health providers, I think the penetration has not been super even. So how do we kind of thinking about bringing like everyone around, kind of modernizing technology, and also thinking a little bit about standards. I think last time I checked, I think the methodologies for even something that could be relatively straightforward like race ethnicity are different between NCQA and OMB and CMS. And how do we think about, and we have to also accept that a number of Hispanic individuals don't identify as white, but the whole combined methodologies for race ethnicity are not really there. And so when we don't have those standards, it can be hard to kind of move together on improvement. So I would say, yeah, technology and standards.
That's come up a lot, I think, across the board. So hopefully something will be done on that. Diana, you guys have access to a vast amount of data to help the states. Can you talk about how you are working with states at the point of care on data collection?
Sure. So I think the best way to think about the third-party data that LexisNexis can provide is really to prepare or sort of amplify the point of care experience. So it's not meant to replace a self-assessment or a referral tool that you would do in a clinical setting. It is meant to sort of help stratify and help get what is a very small amount of people resources to what is a big problem. So being able to work, I think we work with a number of states and providers to help pull this data into their risk and care coordination framework to be able to flag who are the at-needs patients. And the other thing I would mention is this kind of third-party data would be very helpful in ongoing monitoring of a patient population. So you might see someone once a year and you do a referral, and that's great. But how are you, monitoring for changes? Because we all know that, people move, people change jobs, et cetera, and that clearly has a massive impact on their social health and social needs. And so being able to have this kind of third-party data in the background to help you flag any changes that would, trigger someone to reach out and check in on someone, I think would be really, really critical. And lastly, I would say program evaluation is a huge part of how we support states and local health departments, and just thinking about when you are doing a program evaluation, how are you linking all this data across different projects? How are you filling in the gaps? Do you have a patient identifier that can go across and really assess, the return on investment that a lot of your very, very helpful social programs and investments have had?
Gary, we've got two kind of specific questions for you. So are you guys using a single risk assessment across, or does each plan create their own? Is there some kind of required data elements there?
Yeah, so we don't require a single one, but we do require 4 core domains to be captured. So housing, food, transportation, and utilities. We do also require one of some optional domains, including interpersonal violence as an example. And as I mentioned, this is a quality measure for us. And so we give a sample to the ACOs where they need to tell us, hey, did we screen this person? Yes, no. If we did screen the person, what are the results of the screen for the 4 core domains? And so we actually do get some information about actual needs, but just for that sample of members.
And there's a lot of interest, I think, in how you guys pay for services, and what's the range of services that you pay for to address HRSNs? Can you talk about that?
Yeah, sure. So I think we think about it in 2 different buckets. So 1, what's in our benefit, our managed care benefit, and then 2, what is part of this pilot program, the flexible services program. So the benefit portion is, as I mentioned, specifically for folks with BH needs and who are chronically homeless, and the services available for them are search and placement for housing, helping someone to get added to a wait list, as an example, or actually going around with a member and identifying where might be some good places for the individual to live. What are some of the preferences they have for their roommates? And then once they've identified the housing, how can we keep them in that housing? The Flexible Services Pilot Program is a little bit broader. It covers both housing and nutrition. For the housing side, it covers those same services, but for a broader population. So it includes folks with physical health needs, or high ED utilization, or someone is pregnant, or someone has a need for help with activities of daily living, as an example. And so it includes search and placement, so pre-tenancy, helping someone to find the tenancy, transitioning into the housing, so paying for first and last month's rent and security deposit. That's a huge one, which is not part of our core benefit right now. It also includes fees for getting a new Social Security card, as an example. And then again, helping people to stay in housing, so figuring out how to better negotiate with your landlord, or how do you be a good tenant. And then we have a fourth housing category called home modification. So if someone needs to install grab bars in their bathroom, that could be used as well. And then on the nutrition side, we have supports for medically tailored meals, grocery store vouchers, food prescriptions, and then education and potentially cooking supplies for folks to be able to cook at home.
Well, we've run out of time, but I want to just give everybody, we'll do a kind of a speed round here, give everybody a moment to give some last words of advice to folks out there who are trying to do this in their states. Why don't we give everybody, 20 seconds. We'll start with Stephanie. What advice would you give folks?
Sure. I think the best advice is to involve your communities from the beginning and ensure that it's not only from the top down, from the bottom up as well.
Great. Chris?
Yeah, kind of along those lines, understand what groundwork has already been laid and how to build upon that and bring everyone along to together in a more standardized way.
Gary?
Yeah, similar vein. I think the more that you as a state employee or whatever role you're playing, identify who knows what they're doing. So whether that's other state agencies, and then if you're setting expectations for your plans or your providers, make sure that they are also partnering with the community and they're not just trying to build everything in-house, because we know much of the expertise lives in the community.
Diana?
I would say, don't let the sort of legal and compliance parts be overwhelming. There are many, many people and states who have effectively gone through this process. And as Jen said, there's a lot of thought leadership out there on how to approach some of these ethical sticky areas. So I think this is new for a lot of us. And so let's not get overwhelmed by sort of how daunting the task can be. There's a lot of people and a lot of great ideas and great use cases that have already gone through this and can serve as a template.
I want to thank our esteemed panelists today. I wish we had another hour to go through questions. We're clearly going to have another session on SDOH shortly. And I want to thank LexisNexis for their support of the program today. Thanks Stephanie, Chris, Gary, Diana for joining us. Appreciate everybody's time today, and hopefully we'll see you next week. Have a wonderful afternoon, everyone.
Thank you.
Thank you.
Thank you.